So, yet again, a warm welcome to everybody, and especially a warm welcome to Matt and to Vicki. So for those of you who don't know Matt, Matt's a clinical psychologist as well as a mindfulness teacher, and he's worked as a psychotherapist since 2006. Matt is one of the oldest members of our MISA community. He was one of the few people who actually got his initial training at UMass in 2003. And he's really continued to be a really important member of our community. Matt has been teaching MBSR since 2004 and then has been teaching MBCT thereafter. So it's really great to see you again, Matt. And Vicki, welcome. Vicki completed her PhD at the University of Cape Town in 2009, which involved a series of functional imaging and lesson studies into the mechanisms of mindfulness, and then spent a further 2 years conducting postdoctoral research at the UCT MRC Brain Imaging Unit, and is currently specializing in the neurophysiology of epilepsy. So you can see that these two are really experts in their field. And we really feel very honored to have you both, and we're looking forward to the talk. So over to you.
Thanks, Janine. Hello, Vicki. Hello, everyone here. Yeah, it's so lovely to be here with you all. I don't get to attend many of these learning forums, and I'm amazed at the number of people that have turned out on a Monday night to listen to information about mindfulness-based cognitive therapy. So yeah, let me just see if I can share this again. I was having some trouble earlier, so I'm hoping that I can bring this up. But the way it will go this evening is I will start and just give a little bit of background about mindfulness-based cognitive therapy. So hang on, let me just see if I can play. Okay, there we go. So I'm hoping now that you can all see this. Okay, if there's a problem, I'm hoping someone will let me know. Otherwise, I'm just going to keep on talking to myself because I no longer can see any of you. Okay, so I'm going to begin, and I'd like to give you a bit of background on mindfulness-based cognitive therapy. It is a theoretically driven intervention. So what I want to do is I'd like to just briefly talk about recurrence in depression and the cognitive elements that leave people vulnerable. I'd like to share a bit about these authors' journey, and I'm drawing heavily from these books. And if you guys haven't seen these books, I would highly recommend it. This will necessarily just be a very short overview and just touching into some of the central ideas of the book. For those of you who don't know, in the top left there is Mark Williams, who was previously at Oxford. He's retired. And then Zindel Siegel is beneath him, who's at the University of Toronto. And John Teasdale is the other one there, who's also retired, who was at Cambridge. And I think next to John Kabat-Zinn, these three men have done more than anyone else to bring mindfulness into the mainstream of mental health care. The quality of the research that went behind this intervention is, top notch. And I think that's what led to its integration into mainstream healthcare, and it's approved by the National Institute of Clinical Excellence in the UK, and it's used really worldwide as a first-line intervention in preventing relapse in depression. And it's gone actually way beyond that to be a kind of broader, a trance diagnostic intervention. And I'll have people coming in, and it's not just my programs, but programs across the world will now have people coming in just for stress and personal growth, and a whole host of reasons, not just as a clinical intervention. I can't let someone in. Okay, so the research part of this, I'm going to leave to Vicki, and you guys are in for a real treat. The two of us presented this at a CBT Congress last year, and she'll go into all the research and the current research that there is around mindfulness-based cognitive therapy. Yeah, this computer, there we go. So like I said, I just want to quickly orientate you guys to particularly recurrence in depression, and then going into the model of cognitive risk, which they worked from, and then their journey, just the main elements of their journey in developing mindfulness-based cognitive therapy, because they actually didn't start out to develop a mindfulness-based intervention. And the books really give a very, I think, humble and honest description of where they started from and how they actually ended up teaching meditation as a way to prevent relapse. So I'd like to take you through some of the main elements of that, because it serves to highlight the aspects of MBCT that are unique and I think relevant to our community. And then I'll finish with just covering some of the elements of a course itself, an overview of its structure, and then also, again, some of the key features that I think make mindfulness-based cognitive therapy a unique 8-week intervention. Okay, so when looking at depression, so I'm seeing that there's comments in a chat. I'm not sure if people are trying to get me, but I can't answer that. If there is anything, hopefully someone will tell me. But it's probably best to wait until after the presentation and then ask the questions at that point. So in terms of depression, we're now going to rewind back to the 1980s, 1990s, when the research was happening, and depression was being, the nature of depression was originally seen as an acute episode, but then people began to realize that, in fact, after one episode, there was a 50% chance of a second. After 2 episodes, there was a 70 to 80% chance of further episodes. So from a short-lived intervention, it was now seen as a chronically relapsing condition. Now, there was a fair amount of success in treating depression in its acute phase using antidepressants and cognitive behavioral therapy and other treatments. And there was talk about maintenance treatment. So once people had gotten better after they'd been treated for the depression, so that's like the first year afterwards, there was a maintenance treatment, both in CBT and in with antidepressant medication that was also successful. But what was needed was an intervention which, once people were well, that prevented coming back, because that really was the bigger problem. And because people were becoming depressed younger, the importance of preventing the recurrence after they were well was becoming a bigger and bigger issue. And when they started out, the one key finding was that there was a 25% less chance of relapse when the patients were treated with cognitive therapy during the acute phase as compared to other treatments. So when they started out, if they were going to prevent recurrence, they needed to really know what are the psychological factors that leave someone at high risk for relapse and recurrence. So what's involved in people's mind that allows them to relapse again? What was cognitive therapy doing to prevent or reduce the chances of that relapse? And can those skills be taught to patients after they're recovered? In other words, into episode when they're still well. So to really understand the model which the intervention was based on, we need to really get our head around these 5 concepts. The names themselves can be a bit intimidating, but it's a really simple, elegant model. And when you unpack them, I think you'll find that they're easily understandable and intuitively true. I mean, it's nice to know that there's really hard research behind it, but it really, to me, makes a lot of sense. So the first idea, which I'll look at, is learned association, then differential activation, cognitive reactivity, rumination, and discrepancy-based processing. So what is learned association, the first of these? So what was discovered is that during a depressive episode, lowered mood occurs alongside really negative thinking, feelings of hopelessness, and fatiguing in the body, feelings of heaviness. And because those events occur together, they get wired together such that activation of any one element of that mood state can activate all the other elements as well. So there was a learned association in a person between the lowered mood state and feelings of hopelessness and helplessness and negative thinking, such as, I'm a failure, I can't succeed. And that was a core factor. So differential activation refers to the really, as the word states, it's activated differently. And so what was discovered is that, and this was really done through mood induction experiments, that people with depression actually react differently to sad mood than the rest of the population or those never depressed. So how they went about discovering this or proving this was that they would induce a lowered mood, such as listening to sad music. I think it was Prokofiev at 50% of the speed. And they noticed what happened in previously depressed people. And there was a few interesting findings, such that it led to negative thinking. It led to an exaggerated negative cognitive bias in memory, so that people were more likely to remember the negative aspects of their history. And it also inhibited the memory for positive events. Now, some of that also happened in the rest of the population that were never depressed, but it happened on a much milder level, and it allowed the never depressed population, or that group, or that sample, to let go of the low mood and the negative cognitions that occurred alongside them. But there was such a strong reaction. It's almost as if the whole network of a previous depressed episode was activated and loaded into consciousness. So the similar kinds of thoughts and feelings that were part of a previous episode could be loaded back on just with sad mood. So there was another really interesting element of this to this, and a difference in the way that people with past depression react differently to a mood challenge than those who have never been depressed. And that's with not only negative thinking themselves, but types of thought. If you just listen to this words, deject. Other of those words seem to be judgments or negative self-reference about ideas of the self: failure, inadequate, loser, pathetic, which are more judgmental. And they found that people who had depression in the past, that kind of thinking was more activated than in the never depressed group. So cognitive reactivity is really, the concept points to how easily the negative material that's there in the background can be activated again. And what was found is that there's actually latent negative characteristics. So you might need, for example, a breakup of a relationship or divorce or something like that. But then with each episode after that, the threshold is much lower, such that eventually this can be activated maybe if someone even just ghosts you, or if you don't get a call up for a job interview or something like that. So people become increasingly vulnerable with each episode. Now, a very important aspect of in understanding relapse is not only what happens with lowered mood, but how people react to that low mood itself. Now, the never depressed group would react to low mood by distracting themselves, turning away from it, whereas recovered depressed people tend to react to the mood by thinking about it, which is like, why is this happening again? And when is it going to get better? And how come, this has happened again, or whatever it is. So it's asking difficult questions which don't have answers, that focus attention back onto oneself and back onto the mood that you're in, which of course would tend to just make it worse and make one feel more hopeless when you can't answer it. So this ruminative, which Susan Nolan-Hoeksema called the ruminative response style, is a very central characteristic of how people in depression respond to low mood, which is different. So you might wonder, if rumination, this style of reacting to low mood, is so unhelpful, then why would anyone do it? And when people are asked, they'll say, well, it's to make me feel better. I figured if I can work out why I'm feeling this way, then maybe I can do something about it. So underneath that is what's called discrepancy-based or gap-focused processing. And that's driven by a difference between where you are and where you want to be. So where you are, feeling sad or tired, exhausted, what you want to be is happy and energized. What you want to avoid is another episode of depression or just being defected. Now, this difference, this gap, sets in motion thinking designed to solve it. And in previously depressed people, that tends to end up in rumination, which ironically or paradoxically just makes them feel worse. So at this point, we really have the model of what leads people vulnerable to relapse. Press
We seem to have lost Matt. Then maybe can you just contact him and check?
Guys, can you hear me?
Yeah, you're back again, Matt. I think it says often that your bandwidth is low. Maybe it would be helpful if you switched off your camera if it was a problem.
Okay.
Yeah, great.
Okay, I'm going to try and get us back there. It's a new computer and I'm still finding my way with it. So, but could you hear everything, Janine, around the model? Are you at the point where we can understand their model of relapse?
Yeah, we were hearing okay. You were coming and going, but pretty much we were hearing. It's just we weren't getting a very good picture, but I'm sure it'll be better once you switched off your camera.
Okay.
Yeah, that's great. That's that we can see well. Thanks.
Okay. I'm going to just try not to go into. Okay, so where we are is at this point, hopefully there was enough bandwidth for you to realize what the model was, what their model was, to understand vulnerability. So this was the cognitive model of vulnerability on which the intervention would be based. Okay. So let me just give a simple example to instantiate this. So this is just the example of Janie. I'll read through it with you. So she would often wake very early in the morning, unable to sleep, with a heavy feeling in her body and thoughts going round and round. Impossible to switch off. She'd sometimes get up to make a cup of tea and sitting in the kitchen with a blanket around her shoulders, reading bits of any magazine that she or her roommate had left lying around, or opening her laptop, trying to answer emails that had come in overnight. At last, exhausted, she'd go back to bed, only to find that the thoughts carried on, going round and round, but now with a new voice. This is terrible. You'll be too tired to think straight today. Why is this happening again? Why can't you ever pull yourself together? What's wrong with you? So if we look at this example, this computer's not acting nicely. We can start to see that first there is the event, not being able to sleep, and then feeling exhausted. And that would then activate because it's been networked before. And there's a backstory to this, which is a few years ago, Jenny was stressed about the amount of work she was expected to do in her job she held at the time. And she'd become really down and had tried to pull herself together before eventually going to see a physician who put her onto antidepressants. She eventually left that job, but still blamed herself for giving in and not managing at the time. So now at this point where she sits up in the morning and she's absolutely exhausted, that then triggers those old memories and the old thoughts and the old feelings that were going around in that previous job. So we can see the negative catastrophic thinking coming back online, the negative views of the future, and negative views of the self. What's wrong with you? And then she responds with rumination. Why is this happening again? Why can't you ever pull yourself together? She tries to think her way out. So if you asked her what you're trying to, why would you do this? She wants to try and figure a way out of it. But unfortunately, that just makes her feel worse. And that would be a typical example that could lead to a downward spiral and a relapse. So how was CBT helping? Remember, if you remember correctly at the beginning, I said that cognitive behavioral therapy, when used during the acute phase, was preventing relapse by up to 25%. And the question then became, well, what was cognitive therapy doing? And what they found is that it wasn't so much the change in the content. So it wasn't because someone had a thought, I'm a failure, and that changed to, well, I've succeeded at some things. What was happening is that in the process of going through a CBT intervention, which may, for example, could be an automatic thought record where you take the thought, such as I'm a failure, and you look for evidence for and against it. As you were going through that process, you were creating some distance from the thought, what's now called metacognition. And you were just getting, and that was creating that space from the thought was allowing you to react differently or make different choices. You weren't so caught. And that is the whole idea of decentering, which became a central element in the relapse prevention program. And that was the way that they were going to go forward to develop an intervention which really built on this idea of decentering. At the same time, it was important to try and catch the low mood before, or at an early stage before the whole depressive picture, if you like, had formed in the person's mind. So there was the second element was to develop awareness around the thoughts and feelings so that people could nip them in the bud and make different decisions. So here's kind of just a diagram of that. There's a moment of remission, there's a period of remission, there's a moment of potential relapse. The idea was if they could catch the negative thinking and nip it in the bud, they could prevent relapse. If the negative thinking patterns were reestablished, that would lead a high probability of relapse. So many of you might recognize Marsha Linehan there, who is the founder and developer of dialectical behavior therapy. And it just so happened, as the story goes, that she was in Cambridge at the time that these authors were together. And she was the one that pointed them in the direction of John Kabat-Zinn and his MBSR treatment or program to help them develop something around depression. So they got hold of full catastrophe living and they went to UMass and they observed what was going on at the Center for Mindfulness. And what they found was that, I don't think I need to go into what MBSR is and mindfulness, but basically what they found was that at the time, MBSR was being used primarily for chronic pain, and they saw that this could easily be applied also to depression. And what they liked about it was, well, there's of course a lot of similarities between chronic pain and a depressive episode in terms of dealing with difficult emotions, dealing with difficult thoughts, and of course body states. But they also liked that you didn't need to have the negative thoughts to develop the skills. because remember, this is an intervention that was designed for people who are well, at least initially. Now it's being used with depression, but back then it was designed for people who are well. And they realized they didn't actually, it would work well because you didn't need the negative cognition, and the group intervention was really cost effective. So they came back from the Center for Mindfulness, and they created a program which they called attentional control training in a similar structure. The guys, it was eight sessions, once a week, 2 hours. And the idea was to, as I said, increase awareness, to notice early warning signs of mood swings and to decenter from negative thoughts, and then to starve the relapse related, your attention out of thoughts and put it onto the breath. You could block, or the idea was you could block some of that negativity. But it didn't really Sorry, Lynn, I lost you again, I think. I'm not sure how much you guys are getting of this.
We got most of it. We just got the last bit when we lost you, but you're back again.
Yeah. I don't think there's anything I know how to do this. I mean, is it still okay for me to continue, or do you think you're missing too much of it?
No, continue. It was much better this last section with your video off.
Okay. Let me try and bring that up again. Okay. So there were 2 core issues. And that is, what if there's still distress after decentering? So after you've decentered from the thoughts, the negative thoughts, and whatever they are, things aren't working out, the world's terrible, but what do you do with all the rest of the difficult emotions and thoughts and body states after you've decentered from them? And also what to do when decentering from thoughts isn't working, when people were struggling with that. Initially, they thought they would revert back to a CBT approach, but there was so. So then they went back, and they went back to UMass, and they had a much more careful look at what was actually going on in the MBSR classes. And what they realized is that this was not about changing, just sitting there and looking at working with thoughts. They realized that what was happening in a class was they were cultivating what they called a radically different approach to people's experience, not just thoughts, but to their thoughts, to body sensations, to their emotions. They noticed that the whole experience was held in a much warmer, kinder, open awareness, not just a simple, narrow changing of attention, for example, from thoughts to the breath. So they realized that their idea of decentering was both too narrow and not specific enough. It was too narrow in that you can't just work with thoughts, you need to work with a whole mind-body state. And paying attention in this way, decentering from an experience can be done with a whole lot of different attitudes. It could be done as part of avoidance, as part of resistance, or it could be done to learn to be with, or in a much kinder way. So what they came to realize is what was needed was not some inner mental mechanism, but a shift into a whole different mode of mind. Now, before I go into talking about modes of mind, I just want to have highlight one aspect that was discovered on their second visit, and that's the importance of the instructor. So what they realized is that people were learning mindfulness, this a way of paying attention with an open-hearted awareness, in 2 ways. One was through the practice and the instructions themselves, But a very important vehicle for learning this was the instructor's embodiment of the practice. They noticed that the instructors weren't trying to fix or give solutions to the difficulties that people brought, but they were teaching them to live in the midst of them. They were trying to help people see how their struggle, their resistance and avoidance was actually exacerbating what they were feeling and creating more distress. They were teaching people to find a calm place to be with, to observe, to invite. And the instructor became a really important aspect of the intervention when they went back and did it again. Okay. So the modes of mind model. This idea might be familiar to many of you. We talk about a doing mode of mind and a being mode of mind, but what exactly are these modes of mind? Now, modes of mind are predictable kinds of mental behavior that correspond to patterns of brain activity. And they can just be distilled into a couple of fundamental modes. And these modes of mind correspond to, if you like to think of them as gears of a car. Now, one of the most common modes of mind that we're on is the doing mode of mind. That might be sorry, Janine. I know I lost you there. It's telling me that it's something's just crashing and crashing here. Have you got me?
Yeah, you're back again.
Back?
Yeah, you're back again. How far have you got in your presentation, Matt?
Oh, you back? Can you hear
Yeah,
me?
we're back. Yeah.
I don't know how much you're getting and how much you're not.
We are getting most of it. It's just that the times that you disappear, so does the presentation.
Okay. So should I just pick up where I am?
Yes.
Thanks for the patience, guys. And I'm sorry about this. Okay. So again, doing mode of mind, you've missed the turnoff that you were meant to take. The mind kicks into a mode in which it's going to notice where you are, where you need to be, how to get there. And of course, it also now doesn't want to make the same mistakes. So it's going to look at where it doesn't want to be. And it will, until you've delivered that parcel, it will continually look to narrow the gap between where you are and the goal that you want to get to. And it'll keep making calculations until you've actually reached the goal of delivering the parcel, and then it will be abandoned until the next one. So I just want to highlight the core features of this doing mode of mind. Is it comes on automatically. You don't choose, you don't you don't say to yourself, okay, now I'm going to think about X, Y, Z. It just immediately comes up as an issue presents itself. It uses thought. It holds in mind where you are, where you want to be, how to get there. It's continuously looking at what's happened and what's going to happen in the future. It also has to know what to avoid. It's focused on the gap between where you are, where you need to be, as it focuses on the goal. And it's very conceptual, and it uses thoughts to navigate its way through. And to do that, it has to treat thought, really judge your progress until you've obviously either reached it or abandoned the goal. So if it's so useful, what goes wrong? Well, what goes wrong is when you try to apply this doing mode to mood, it has a different effect. So if you just look at Janie, where am I? I feel sad and exhausted. Would I want to be happy and energized? and what I want to avoid, another episode of depression, feeling dreadful, or being defective. Now, in order to try and work this out, you have to hold in mind all of these aspects, including where you are and what's wrong with you. And as you think about this, you feel worse, which takes you further away from the goal state that you want to achieve. So when you apply doing mode to emotions such as these, the process of that one would follow in order to achieve the goal actually takes you further from it. So it just increases the size of the gap rather than decreases it. And sometimes what the mind will do is that it will double down on its efforts to achieve the goal. And this is a tragic case in which the mind goes into what we call doing driven mode of mind. And that's when the mind just won't let go. And that's really the most dangerous mind state to be in when dealing with sad mood, because we just cycle on downward and follow a downward spiral. So what is the alternative to this doing mode of mind? And that's the being mode. And the being mode of mind is just like forward and reverse gears of a car. The being mode of mind is an incompatible mind state. So whereas doing mode would be automatic, being mode is much more intentional and conscious, whereas the doing mode is conceptual. Being mode is a much more direct, sensory, experiential mode of mind, more in the present. It's open and approaching all experiences, allowing things to be as they are, very much gathered in the present rather than in the past and the future. Thoughts are part of our experience as mental events. We're not caught in a conceptual thought world. And as opposed to a single-minded, narrow focus on achieving goals, that's very characteristic of the doing mode. When we shift into a being mode, we're sensitive to the wider context, the quality of our experience, and our own well-being. So, and I think just to really bring it home, this is a mode of mind. So you could be washing the dishes in a being mode of mind, but you could be meditating in a doing mode of mind. So where you're trying to achieve a particular state, whether it be relaxation or more mindfulness or anything else. So how does mindfulness fit into this model? Well, the definition is there. All right. I'm back. Are you back?
Yeah, we're back. Welcome back.
So so basically, it works out that mindfulness is the tool that allows us to shift from a doing mode to a being mode, and it characterizes the being mode of mind itself. In fact, I prefer the term being mode of mind to mindfulness because it brings out so many more of the elements. I'm just aware of the time, Janine. I'm not sure how much of this I should really cover. So that was really understanding the model of MBCT. This section would be just talking more about the program itself. Is there time to do that? I don't even know if you're there.
I'm not sure if there will be, because we'd also like to have time to listen to Vicki. Can you cover it just very quickly?
So I don't know. Okay. So MBCT is similar to MBSR in terms of the structure of the 8 weekly sessions. In terms of time, the first half is really about concentration, steadying the mind, and in the second half we get to wider awareness and relapse prevention. The themes and practices going from autopilot, so some of this should feel very similar to MBSR, and increasingly I think the two are very similar. Autopilot, coming home, time traveling, recognizing aversion. And I think aversion is a really important element. As you can see, it's the title of week 4, because aversion is the is the core characteristic that leads people into rumination. Not wanting experience sets in motion that discrepancy-based processing, which leads to rumination and which can lead to relapse. So having people be really sensitive and learn to see aversion when it arises is a really important element of MBCT. And then from the second half, it's about opening and turning toward experience with kindness, and similar to MBSR, you really want to be emphasizing acceptance, allowing, letting be, and that starts in session 5. Of course, it's there all the way along, but this is really where we turn towards difficulties, learn to work with them in the body, learn to work with thoughts as thoughts is an element of session 6. So, of course, thoughts are just one aspect of experience, but a very important one. And the negative elements, negative thinking is a really creates a lot of vulnerability, and learning to see thoughts as events in the mind and not as true or real aspects of our experience is key to working with them. Kindness in action, I think that's also a bit different from MBSR. I don't know, are you guys there?
Yes, we can hear you, Matt.
Oh, okay. I can't see anybody. I don't know who's there and who's not there. I think, sorry, I'm going to try to go back. Then I think I'm just going to say one more thing, which is about week 7, the kindness in action. This week, so this is, I really bring a lot of kindness into the way that I teach. It's not explicitly a part of MBCT to have loving kindness and work with self-compassion, but I bring it in, and particularly in session 7, which is really about the skillful use of activity as a way to bring kindness to oneself. And it's not just doing things that you enjoy or doing things that nourish you, but understanding the importance of having that grow out of a sense of kindness just changes the whole quality of the experience. Yeah, I think there's a lot more that I could say, but I think I'll leave it there. And maybe if there is questions afterwards, I'll be happy to answer if there is anything around the MBCT. And Vicki, I'm going to let you take over. I'm sorry for going over. I don't even know if you're there.
Okay, that's fine. Can you hear me?
Yes, I can, thanks.
Okay, and can you see the slides?
Yes.
Okay, excellent. That's a good start. All right, so I'll just see how far we get with the research as well. And I think my aim will be to cover the most important papers, and maybe we can hold over the neuroimaging work for even another talk, because that can be fleshed out into a much grander talk about what neuroimaging research is and how we study the brain in different ways. So I'm going to be talking mainly about mindfulness-based cognitive therapy in terms of its efficacy to treat depression, and also look at relapse to depression, which of course, as Matt said, are the 2 primary areas of interest in MBCT, but also looking at some evidence from studies looking at MBCT's efficacy in treating other psychological disorders. It obviously goes without saying that any therapeutic intervention needs to be scientifically investigated so that we fully understand the benefits and risks. And I think as a clinician, it's very important to consult the latest research findings to make sure we are practicing in an evidence-based approach. And just looking at the interest in mindfulness over the years, it's very clear from this graph how the research interest in mindfulness has grown exponentially over time. And unfortunately, this graph only takes us to 2020, so we don't have the last 5 years. But I mean, it's fairly self-evident that publications are increasing over time. The blue bars represent research studies, and the orange bars represent reviews of published studies. So you can see the trend here. Of interest is that 2/3 of the total body of literature was produced between 2015 and 2020, and presumably we would see, if we had an updated graph, that this would have grown in the last 5 years as well. Almost half of these publications were produced within the discipline of psychology, but what's noteworthy is that over recent years, there's been a growing interest from other disciplines like public health and occupational health and general internal medicine. So there's a growing interest from other disciplines in the application of mindfulness and mindfulness interventions. So this image is the result of a bibliometric analysis, and what that is when keywords that are noted in a publication are entered into an analysis over a period of time, we can derive a model like this that shows us the most commonly occurring variables or areas of research interest that coexist with mindfulness. So in other words, when we note keywords in our publication, if we enter this into an analysis over 10 years with all of the mindfulness research, we will see the most important or most common primary outcomes that have been of interest in these studies. So you can see here, which is not very surprising, is that the most common areas to be studied with mindfulness or in relation to mindfulness: meditation, depression, anxiety, emotion regulation, attention, stress, health, and so on and so forth. I can share these slides so you can have a more in-depth view at that in your own time, but I always find these are such beautiful graphics to represent something in such a simple way. So coming back to evidence-based practice, and I think it's important to say that not only reviewing the literature is important as a clinician, but also just keeping in mind the strengths of the studies in terms of the methodology used, so that you have an appreciation of the robustness, the reliability and reproducibility of the findings. You know, we have different levels of evidence, and it's very important to bear that in mind when consulting the literature. So, for example, you can see here, you know, expert opinion and editorials are the lowest level of evidence we can produce. And even though someone might be working in a field for 20 years and they might have very informed opinions on working with a certain therapeutic approach, it still is the lowest level of evidence we have in terms of the efficacy of an intervention. So case reports, case studies, similarly so. And as we climb up the pyramid, so we get to stronger and stronger forms of evidence. And when we get to our level 1 evidence, we can see here randomized controlled trials, which is the gold standard of research. So that is where we are studying a therapeutic intervention in relation to a control condition. And the study is very stringently controlled. And this means the effect sizes that we see are much smaller, and the findings are much more robust. Now, even above randomized controlled trials, we have meta-analyses of systematic reviews and randomized controlled trials, which pool the results of randomized controlled trials over a period of time. And then using very specialized analytical tools, they collate the data and arrive at much more robust findings. So these are what we would call level 1 evidence studies. And those are the ones I'm going to be focusing on in this talk. So in terms of this level 1 evidence for MBCT and depression, I'm going to show you some of the most recent findings. And what I've done here for each article I'm going to be showing you is there's 2 ribbons here in the top right, and the first ribbon represents the strength of the study from a methodological point of view, and the second ribbon is the strength of the findings in favor of MBCT. So I just thought it might be useful just to highlight that at the top of the study. So this was a network meta-analysis published in 2020, which compared long-term effectiveness of MBCT for prevention of depression and also time to relapse against depression. And in the study, they collated data from 14 randomized controlled trials, which collectively studied 2,077 patients for relapse of depression. And then they collated data from 13 randomized trials, which collectively studied 2,017 patients for time to relapse. So those were their two primary outcomes, relapse of depression and time to relapse. And what they found, so a network meta-analysis will produce graphs like this, which are referred to as forest plots. And a forest plot gives you an idea of the intervention of interest against controls, so against the control arms. So as you can see here, anything to the left of this midline favors MBCT outcomes, and anything to the right favors the control. So in our first forest plot here on the left, we're looking at MBCT compared to control treatments in terms of relapse of depression. And what these bars show us is that, for instance, at the top here, there would be a 34% greater risk of relapse of depression in a placebo arm compared to an MBCT trial. Treatment as usual, there would be a 20% greater risk of relapse to depression compared to MBCT. And so we go down. The only two that were significant here, were significant outcomes, were MBCT in relation to treatment as usual. And you can see there that MBCT was favored with regards to that comparison. And also MBCT with maintenance antidepressant treatment was favorable over MBCT on its own. You can see here the comparison of MBCT versus cognitive therapy. There was just a marginal difference between the outcomes of these two interventions. But like I said, the only two significant ones there are those highlighted with the red asterisks. On the right-hand side, these were the results for MBCT compared to control treatments in terms of time to relapse of depression. So in our first bar, looking at placebo versus MBCT, this would indicate that there was a 77% faster time to relapse of depression in a placebo group compared to MBCT. And there was a 43% faster time to relapse in patients undergoing treatment as usual compared to MBCT. And once again, the trend you can see is very similar here, and a highly favored outcome when MBCT was combined with maintenance antidepressant treatment. Interestingly, cognitive therapy also fared well there in terms of time to relapse. But the three significant outcomes there were the MBCT plus maintenance antidepressant treatment, MBCT over treatment as usual, and MBCT over placebo. So in this next study, this was a systematic review of meta-analyses and looked at 9 randomized controlled trials comparing MBCT and treatment as usual, looking at the effect of MBCT on depression and suicidal ideation in major depressive disorder. So the 9 randomized controlled trials that were included in this study collectively looked at 1,159 patients. And these patients were studied in terms of their suicidal ideation and their symptoms of depression, which were measured using the Beck's Depression Inventory, Hamilton Rating Scale of Depression, and the Beck Scale of Suicidal Ideation. And what they showed is that these were 5 of the randomized controlled trials. And you can see there again, when you look at the midline, anything to the right of the midline favors mindfulness-based cognitive therapy over treatment as usual. And all of these trials showed that MBCT was favorable over treatment as usual in terms of symptoms of depression when using the Beck Depression Inventory to measure depression. There was an overall significant effect, which you can see here as 0.013. So quite convincing when depression was measured with the Beck's Depression Inventory. And on the right here, same, but depression was measured using the Hamilton rating scale of depression. And you can see here a similar trend again, that the 6 trials that were included in this analysis, all but one showed significant results in favor of MBCT over treatment as usual for the treatment of depression, using the Hamilton scale as their measure. And on the lower section here, you'll see this is a forest plot carrying the results for suicidal ideation, which was measured with the Beck scale, so the Beck scale for suicidal ideation. And these 3 randomized controlled trials all showed improved benefit of MBCT over treatment as usual for suicidal ideation. So quite positive results in favor of MBCT produced by this study. So looking at this next study, the focus was on suicidal ideation during depression. So the one before looked at suicidal ideation in major depressive disorder, and this is suicidal ideation during depression. And they compared MBC randomized controlled trials, and they included 7 randomized controlled trials in their analysis, which covered 479 patients, and they looked at mindfulness-based MBCT versus treatment as usual. And what they showed here in this top section, they looked at MBCT versus treatment as usual, and you can see there anything to the left of the midline favors MBCT. So all of the randomized trials that were included in this analysis favored MBCT. But when they looked at MBCT versus continued psychoeducation, they actually found that continued psychoeducation had better outcomes in terms of suicidal ideation during depression. And then lastly, so similar comparison here, looking at an application of cognitive behavioral therapy, where mindfulness also performed well. But overall and collectively, the MBCT group was, the overall effect was significant in favor of MBCT for suicidal ideation and depression. I'm not going to go into that now. Lastly, this study looked at the current state of evidence for MBCT in the treatment of bipolar disorder, which, as you may know, is what we have at this point are quite inconsistent findings, actually. The study was slightly weaker in its design because they included uncontrolled studies in their meta-analysis. But they looked at 10 studies looking at the effects of MBCT on depression, on symptoms of depression, anxiety, mania, stress, and emotional regulation in patients with bipolar disorder. And what they found is, in terms of symptoms of depression, those trials that measured pre-treatment and post-treatment symptoms of depression found that MBCT was favored or produced favorable results in terms of some symptoms of depression. And in the trials that compared the experimental group to a control group, so for example, the control group could have been a waitlisted group where the experimental group received MBCT and were measured before and after the intervention, and the control group would have been waitlisted and measured at a separate time. So comparing an experimental and a control group, you can see that MBCT was also favored over the control arm. And when these findings were put into a time analysis, checking whether the the outcomes held over a 3-month period, you could see that they quite effectively held over a three-month period, but not over a 12-month period. So this is very interesting from a clinical point of view, because we need to look at options of repeat programs or possibly check-ins over time, because the positive results, particularly in patients with bipolar disorder, don't seem to hold over time. So a similar finding with anxiety, in terms of pre and post outcomes of anxiety, also MBCT was brought about significant improvements when you look at the overall effect size. And when MBCT was compared to a control, there were favorable outcomes in terms of MBCT, but these were non-significant, because you can see here the overall effect was not significant. Again, at 3 months, positive outcomes held, but at 12 months, they didn't. Lastly, with symptoms of mania, there was no positive outcomes. So it seemed to be, from what we understand from these randomized controlled trials, MBCT doesn't appear to have a benefit for symptoms of mania in bipolar disorder. So I thought it was interesting to maybe include this study, because this study looked at MBCT versus CBT. And of course, CBT is currently the recommended first line of treatment for depression. So it's interesting to see, how does MBCT hold up to CBT? And in this study, this was also a meta-analysis, and they included results from 30 randomized controlled trials, which collectively studied 2,750 patients. 16 of those trials compared MBCT with CBT, 9 compared CBT with an adapted mindfulness intervention, and 5 compared CBT with MBSR. And they used minimal clinical differences in calculating outcomes, which is a very robust way of measuring outcomes, because obviously, as the name suggests, patients, it's actually a clinical difference. So it's not on a questionnaire or on a scale. There's actually a clinical difference. So very robust study, and you'll see here, they found the interventions were equivalent post-intervention at follow-up. And this forest plot shows you, I mean, here are our confidence intervals, and it shows you all of the trials that were included in the study and how there was a overall non-significant difference in outcomes versus for MBCT over CBT. So the two interventions very comparable in terms of their efficacy in treating depression. And I won't go into that. Well, interesting to note that in that study, in the findings, they show that MBCT versus CBT was the most comparable in terms of outcomes, compared, as one would imagine, compared to MBSR and CBT or other mindfulness interventions in CBT. So MBCT and CBT were the closest in terms of their outcomes in treating depression. So just very quickly looking at some evidence we have for MBCT in treating some other psychological conditions. And of course, one of those that's of primary interest is anxiety, given what we know about mindfulness and its efficacy in treating anxiety. And in this study, the authors were interested in looking at the efficacy of MBCT and MBSR on anxiety disorders. And the primary outcome was anxiety, with a secondary outcome on depression and quality of life. And they included 23 randomized controlled trials, which collectively studied 1,815 patients. And what they found here, in terms of clinician-rated anxiety, there was clinicians rated CBT to be superior to MBSR in terms of anxiety outcomes. But in patient-rated anxiety, so patient-rated outcomes, patients rated MBCT superior over treatment as usual, as well as MBSR over treatment as usual. So this was again in favor of mindfulness interventions over treatment as usual, and both of those were significant. These other findings are were non-significant. And in terms of depression, MBCT, and I'll only mention this one because it's the only one that's significant, MBSR was valued higher than treatment as usual, or rated better than treatment as usual on symptoms of depression, which is interesting because MBSR is not typically used for depression per se, but that's what they found. In terms of MBCT for generalized anxiety disorder, this study included 6 randomized control trials and used the Beck's Anxiety Index to measure. All of those trials used the Beck's Anxiety Index to measure anxiety. And MBCT was shown to be significantly beneficial over treatment as usual in all but one randomized control trial. So this is specifically for generalized anxiety disorder. So very favorable outcomes, very strong effects for MBCT over treatment as usual. So looking at MBCT for post-traumatic stress disorder, this is a relatively weak study. They only included 4 randomized control trials, and only 2 of those actually looked at MBCT, which was collectively a total of 85 patients, so not incredibly strong. But they showed significant improvement in PTSD symptoms in MBCT participants after an intervention. And they showed that MBSR had, in moderate to severe trauma, had a greater reduction, but in mild trauma, symptoms did not significantly differ. So when trauma is more significant, then mindfulness-based interventions seem to be favorable. But one has to take these findings with caution because, like I say, the study is really a preliminary study, which then will obviously inform further study. And looking at MBCT and substance abuse, this is also a relatively weak study. They only included 30 randomized controlled trials. And mindfulness interventions we can see here. I'm just going to, yeah, I don't have that there. They show to reduce the frequency and quantity of alcohol and drug use, and increase the rate of abstinence. So again, preliminary but important findings for the use of MBCT in substance abuse. And lastly, I just wanted to mention this study that looks at the effects of MBCT on sleep in mood disorders, which is a very important variable, as any clinician will know. You know, sleep plays such a big role in mood disturbance. And in this study, they combined different types of mindfulness interventions on sleep in patients with depression and anxiety. And it was a systematic review of 10 randomized controlled trials. And like I say, they looked at an adapted mindfulness-based intervention, MBCT, and you'll see here a few others. And they showed that all structured interventions applying mindfulness improved sleep significantly. So that's a positive finding in terms of just treating the sleep disorder as a comorbidity of mood disorder. So this gives you, to kind of summarize where we are, given all of this evidence that has been accumulated. These are clinical practice guidelines, and this is what is being recommended so on the top of the table, you'll see there the Royal Australian and New Zealand College of Psychiatrists, their clinical practice guidelines. And recommended for all of for anxiety and depression, time to relapse, but insufficient evidence for the efficacy of MBCT in treating patients with bipolar disorder. Similar guidelines presented by the Canadian Network for Mood and Anxiety Treatments, recommended for relapse prevention, recurrent depression and depressive symptoms, but insufficient evidence for its efficacy in bipolar disorder. And the NIH recommended also for relapse prevention and symptoms of depression. And then in terms of the APA clinical guidelines, recommended, but in combination with treatment as usual in the initial treatment of a mood disorder. So positive outcomes for MBCT, I think, based on what we currently know, but it's probably obvious we have some gaps in the knowledge here, because depression would still be the primary outcome of interest in most randomized controlled trials and meta-analyses, because that is what MBCT was designed for. But we're really starting to try and investigate and interrogate what MBCT or what promise it holds for the treatment of other psychological disorders, particularly anxiety, PTSD, and substance abuse. So I'm not going to touch on the mechanisms of mindfulness, and I think I should perhaps leave it there so there's time for questions. There is more to say about what we found in structural and functional imaging studies, but like I say, I think that might be a whole conversation for another time, because one can get really, in depth with that. So Janine, I don't know what your thoughts are.
Yeah, Vicki, I mean, maybe we can open it up to the floor and have some discussion and some questions.
Okay, and just to say, if anyone would like any of these studies, PDF copies, then just do let me know. I will show you at the end. Here is my email address, and you're welcome to email me, and I can send you some of the slides or studies themselves.
Yeah, a very big thank you to both Vicki as well as Matt. Perhaps we can open up to questions, and if anybody's got any questions, this is a good time to ask our two experts. So I have lots of clapping hands. Chiara.
Hi. Thank you both so much. That was really interesting. The question I have is for Vicki. And just in terms of the studies, in terms of relapse and time to relapse, are these studies requiring participants to continue with mindfulness practice beyond the 8-week program, or not to continue, or both? And if it is both, is there greater efficacy in cases where participants continued with the practice rather than not continuing?
Yeah, that's such an important question, because what some of these studies have shown is, I mean, because of the difficulty in conducting a randomized controlled trial and the expense of conducting a randomized controlled trial, your research question has to be very focused. And in order to keep the study as robust as possible, they looked at an 8-week intervention, so a manualized 8-week intervention, and then used before and after measures or comparison with a control group. So while the results were favorable, in instances where there was any kind of discrepancy, they always mention in these papers, when patients are followed up and they have booster sessions of the mindfulness training, the results are that much better. But the randomized controlled trials haven't produced any evidence of that. They rather just suggest that based on what they have found going forward, because even once a study is finished, researchers often take an interest in following those patients over time. So it's more of an afterthought than what was really studied. But I do know for a fact that they do recommend booster sessions for patients and say that the positive outcomes hold over time in a more steady fashion when they receive those booster sessions.
Thanks.
Leslie Ann?
We have load shedding here, so forgive me, for not being able to put on my camera. Mine may be very a question kind of that I'm thinking of, because we run a shelter for abused women and children, and obviously we encounter a lot of these problems. Do the studies, are they applicable to adults and children? Or has there not been any studies on that? And then my second question to that would be, how could we, what kind of practices are there that we could introduce to children in order to get them through the traumatic experiences that they've witnessed? Thank you.
So these trials that I've presented to you and these meta-analyses that I've presented to you this evening are all in adult populations. There is research in pediatric populations as well. And I suppose that would be another conversation. I'm not aware of any level 1 evidence in terms of randomized controlled trials or meta-analyses of randomized controlled trials in children. With MBCT, I'm now speaking specifically.
Right.
But yeah, so the research presented tonight was just for adults. Yeah.
Thank you so much.
Matt, do you want to add to that?
Sorry, to be honest, it broke up. I didn't even get the question. I'm like in and out.
Oh dear. Okay. Well, thank you so much for having some time in.
Yeah, I realized how much I was out when I was trying to follow Vicky's presentation. I got like 50% of it. So I'm sorry, but I realized my internet connection's pretty not good this evening.
Maybe it's the load shedding.
Yeah.
Yeah, Claire?
Hi, thanks so much, Vicki. That was really interesting. Just as a follow-on from Kiara's question, because I was going to ask something around that. You mentioned the post-study intervention or post 8-week course. What are you thinking of? Are you thinking of as a more of just follow-up meditation in a group, or is it is the idea about reminding them of what they learned in the 8-week course?
So I suppose each clinician works slightly different with patients when they follow them up. I know that typically it's done in the form of and I don't know, Matt, Linda, you would be better probably to say, but I think that it's normally done in the form of a retreat, like a month or two after the intervention, when the group comes together again and they collectively practice, and they might revisit some of the concepts that they learned and have an opportunity for inquiry. So it's just like kind of a reinforcement of what they did in the course itself. But as I understand, normally in the form of a retreat. And when I've run MBCT interventions, that's what I've done with patients in my groups. And they really enjoy that. They really look forward to meeting again as a group and having the opportunity to practice some of those skills that they learned. Yeah. But I suppose it's different for every clinician,
Because, sorry, may I have a follow-on sort of question, Janine?
Yes.
Because I work with people with chronic pain, and I'm delivering a mindfulness, individual mindfulness, because a lot of them have very different issues around chronic pain and anxiety. I mean, I'm a physiotherapist, I'm not a psychologist, so I find it quite difficult to be able to put together a course, because they're at such different places in their pain experience, that and you know, quite a number of them actually people in their 80s with anxiety, actually, which I find interesting. You know, I wonder if there's any studies on individual teaching of MBSR. I mean, I know that the group is such a useful therapeutic tool as well. So, you know, it makes me a bit sad, really.
So there certainly are. There are studies that have looked at individual MBCT interventions, and it's also a preliminary area of study, because typically it's been offered in a group setting. But as far as I know, and I stand to be corrected, but as far as I know, the results are very promising for individual interventions as well.
I can try come in here. I might have missed some of the question, but I'm getting the end bit around a group intervention, and there was a slide that I didn't get to, which is the importance of the group and a program, and I'm sure it applies to MBSR as well. You know, after every group I teach, I give a post-intervention assessment, and invariably the group finds learning from the other group members a key element of the learning process. Once you've created a safe environment and people begin to share, you can't underestimate how valuable it is to have your experience normalized when you realize other people have similar experiences as they go through this, similar structures to their mind, and the difficulties with, you know, with trying to push away, and the struggles with trying to be with particularly chronic pain, or it could be low mood, or whatever it is. So, I mean, if there's huge variability, if the group is really different, then, you know, perhaps there is an argument for doing it individually, but you lose a lot. You lose a lot. Yeah.
Linda, did you want to add to that?
Yeah, I can just add a little bit, and I'm sure Janine, maybe you have more to add, but yeah, Claire, just to always remember that the group work is about inviting people and meeting people wherever they are. And that's why in an MBSR, you can have a range of people with different conditions, different functionalities. But the practice is really about, you know, can we meet what's here with kindness, with care, with equanimity? And that means that we can have people in the group with a range of experience, and very often there's a learning that can happen from sometimes the people that are struggling the most, but somehow they manage to embrace the practice in a particular kind of way, and that, you know, that becomes inspirational for others in the group. So yeah, I guess just to invite a curiosity around how to hold that space with people with different conditions. And also there are beautiful pain programs, which I'm sure you know, like Vidamala Birch has done a beautiful program on pain, which might help support the way that we adapt for particular populations. Because I think, you know, the conversation now is really around adaptation, and yeah, which is always interesting, and yeah, so much to learn around that.
Thanks. Does anybody else like to add something or ask any further questions? Vicki or Matt, is there anything further you'd like to add?
No, I'm good, thanks.
Matt?
I could try, but I'll probably break up. The connection will probably break up before I finish. So, yeah, I'll probably leave it there.
I'll give it a shot. We can hear you for a while.
Yeah, no, almost in 5 minutes. Just, yeah, I'm sorry about the breakup. If anyone would like more information around this, they are welcome to contact me. There was a lot of areas I didn't get to. So maybe just to share the sentiments and the generosity of Vicki, just if anyone is interested to yeah, hear more about MBCT and any element of it, you're welcome to reach out. I'll be happy to share the slides or the information around it. Yeah.
Yeah, so really thank you to both Matt and Vicki. They both really are experts in their field and have got so many years and years of experience of working with patients in this very important area, and to be able to summarize it in ways which make it understandable for us all. So thank you so much. As they're both saying, is these are actually both huge topics which would probably be weekend workshops in themselves. But I'm sure that if anybody would like to find out more, is to contact either us at the Institute for Mindfulness or to contact Lynn, and we'll pass on Vicki and Matt's details, or to contact them themselves, and that we will be putting this recording up on the EMISA website in the next couple of days. So really a very big thank you to you all, and thank you community for arriving and being here and being together. It was really a joy to see you all. Thank you.